I have long had a philosophy, which is in God we trust, but everybody else better bring data to the table. And I truly live by this philosophy. So I'm going to show you a lot of data today. But my dream, my hope, is we're going to do more than look at this data. We're going to use this data to improve the well-being of nurses, which is going to impact quality and safety of healthcare. We have long had a saying, right? It takes 17 years to translate evidence. That is if you're blessed. It often takes 20, 30 years to translate evidence into practice. What year did we say all nurses will have bachelor's degrees? That was in 65. And we're not there yet. So please, let's use the data we have for change. So think about this. 50% of clinicians, including nurses, are burnt out, depressed, and suicidal. 50%. This is a public health epidemic. In 2017, the National Academy of Medicine said, we need to do something more about this situation. So they launched the Action Collaborative on Clinician Well-Being and Resiliency. Those of us on this Action Collaborative are generating evidence-based solutions to improve this epidemic. Tim referred to this. Nurses, we do a great job of caring for everybody else, but we often don't take care of ourselves. And in this NAM Action Collaborative, we want to be careful at not blaming the clinicians. We want to say, yes, can we do a better job at our own self-care? But there are so many system issues that lead to the burnout, the depression, and the suicide rate. The latest data on nurse suicide shows male and female nurses have significantly higher suicide rates than the general population. So I'll never forget where I was when I saw the media on this study, and I gasped, and I said, this can't be accurate. But that study showed nurses have 3 times the rate of obesity, diabetes, high blood pressure, and depression than physicians. So we formed in the American Academy of Nursing a Million Hearts Committee. And we said, we want to see where nurses are at in 2018 to follow up that Gallup poll study. So we surveyed over 3,000 nurses from 19 healthcare systems across the United States. This published data is on 1,800 of those nurses who were all practicing. In this study, we found more than 50% of these nurses reported suboptimal physical and mental health. 30% almost reported being depressed. But the nurses who said, we work in a healthcare system that supports our well-being, had better physical and mental health outcomes. We were the first study that showed depression was the leading cause of medical errors. Depression. But nurses who were in poor physical and mental health made more medical errors. Now, the other thing our study showed, the longer the shift work, the more errors. The poor health of the nurses. We need to stop 12-hour shifts based on best evidence. This is not a new finding. We've been finding this for a long time, but we continue to promulgate these 12-hour shifts. So, as part of the NAM Action Collaborative, I pulled a team together and I said, let's do a systematic review. Let's take a look at what interventions lead to better outcomes in physicians and nurses. You are seeing this data hot off the press. We are getting to submit it now for publication. We, in our search, discovered 11,000 studies, but narrowed it down to 43, because we only wanted to look at experimental studies. The length of the interventions ranged between 1.5 to, believe it or not, 92 hours of mindfulness training. The majority of studies focused on giving nurses and physicians mindfulness-based interventions, cognitive behavior therapy-based interventions, and reinforcing lifestyle behaviors. So we couldn't even pull this data into a meta-analysis because these studies were measuring everything in the kitchen sink. So one thing we need to do as we move forward, we need to measure similar outcomes so we can pull data in meta-analyses. So, not rocket science findings. Mindfulness works. It works. Cognitive behavior therapy works. It works. So now we've got to make sure we get that to more of our clinicians. Technology-based interventions didn't work most of the time. People expect quick return. on investment, or they want quick, easy answers. It takes time to change behavior. It takes time for thought change to occur with cognitive behavior therapy. I'm not saying apps aren't good, they are, but it needs to be high tech with some touch, personal touch over time. Studies with significant outcomes were done more rigorously. We need so many more randomized controlled trials looking at what interventions work. So over the past 25 years, I've developed a CBT-based intervention. It's called COPE in the literature. We adapted this intervention for new nurse residents. We integrated that into their program. What we found, significant differences in depression, stress, anxiety, and improvements in job satisfaction. So we are really hoping to scale this intervention to nurses across the United States. The intervention emphasizes how you think directly relates to how you feel and how you behave. And again, we got wonderful improvements and differences in those who got this CBT intervention. So when you think about what's the #1 killer in America, I'd have to tell you it's still cardiac disease. But if we put together all causes of death and disease, it's our behaviors, including the long sit times that we engage in. We must move more and sit less. As an example, I didn't fabricate this. This is a real fitness facility in the state of California. So you have a choice. I can either walk the stairs or take the escalator to go work out. A group of psychologists studied this, and they found an average of 2 people a day took the steps. So when we think about building hospitals, healthcare systems that support nurse well-being, culture, as Molly said this morning, eat strategy for breakfast, lunch, and dinner. You have got to tackle evidence-based interventions across all these particular areas. It's not going to work unless culture supports it and changes it. But culture change is what I call character building. Most people don't change unless crisis happens, sadly. At Ohio State, we have put into place the socio-ecological framework. We target wellness interventions to the individual, family, and social network, workplace culture, and policy. And we diligently track outcomes. And for any C-suite people in the room, I'd like to share our return on investment in wellness is huge. In fact, we are in the 3rd year of a negative healthcare spend at Ohio State as a result of what we've done. So lastly, my recommendations. We need more RCTs, but please, everybody, let's take the evidence and rapidly get it into practice. The lives of our nurses and our patients are really dependent on that. Just want to point out, NAM released 2 case studies of successful places for this that you can refer to. And lastly, my mom stroked out right in front of me when she sneezed when I was 15 years of age. But the saddest piece of my mom's story, she had a history of headaches for over a year. My dad kept saying, go to the doctor, figure out what's wrong. She went to her family physician 1 week before she died. Diagnosis, high blood pressure. Given a script for a blood pressure medication that my dad found in her purse after she died. Please take better self-care. And if you don't do it for yourselves, do it for the people who love you. Thank you.
Thank you, Dr. Melnyk. And now Dr. Wolf.